welcome. Glad you could join us. We're lucky enough today to have two wonderful doctors for our kind of question and answer period that we're going to have for this session. I will introduce them. You've probably heard them speak before if you were at any of the other sessions. But first we have Dr. Andrew Bauer, and he is a pediatric endocrinologist and the director of the Thyroid Center at the Children's Hospital of Philadelphia in Philadelphia, Pennsylvania. Dr. Bauer retired from the United States Army after 29 years of service, to include 2 combat tours in Iraq. His clinical and research interests are focused on the study of pediatric thyroid disorders, including hyperthyroidism, hypothyroidism, thyroid nodular disease, thyroid cancer, and familial thyroid tumor syndromes. Dr. Bauer serves as co-chair of the American Thyroid Association Pediatric Thyroid Cancer Guidelines and as a member of the ATA's Board of Directors. In 2018, Dr. Bauer served on the World Health Organization International Agency for Research on Cancer expert group that published guidelines on thyroid screening after nuclear disasters. He has spoken at many ThyCa events, and Dr. Bauer is a ThyCa medical advisor also. Second doctor, which is a wonderful surprise. We didn't know he'd be joining us, but we're glad he's here. Dr. Jonathan Wasserman. He's a pediatric endocrinologist and associate professor at the Hospital for Sick Children, Toronto, Ontario, Canada. He also serves as a project investigator of genetics and genome biology at the Research Institute. Dr. Wasserman's research focuses primarily on pediatric thyroid cancer and spans both clinical and translational domains. His research includes genetics and genomics of pediatric papillary thyroid cancer, healthcare utilization patterns among young patients with thyroid cancer at diagnosis and during follow-up, and the identification of prediction models to improve assessment of thyroid nodules in children and to gauge malignant potential. He received his medical training at Harvard Medical School and the Massachusetts Institute of Technology, and subsequently pursued an internship and residency in pediatrics at Children's Hospital in Boston. He previously earned a PhD and completed postdoctoral training in genetics at the University of Cambridge, England. Dr. Wasserman serves as co-chair of the American Thyroid Association Pediatric Thyroid Cancer Guidelines. So thank you both so much for joining us again. Welcome. And I think this will just be a question and answer session. So if any of you have questions for Dr. Bauer or Dr. Wasserman, this would be a great time. You get to speak with world experts on pediatric thyroid cancer, free of charge, no poking and prodding or anything for your kids. So
as Pam said, I think we just wanted to give everyone an opportunity to raise any questions that may have come up on previous sessions at this meeting or elsewhere, and meant this to be very informal. You can either put questions into the Q&A, or I think if you raise your hand, then we will be able to unmute you and actually hear your voice.
Mm-hmm. Yep.
So we don't have any prepared remarks.
Okay, and Donna has a question. Donna, I'm going to ask you to unmute yourself and go ahead.
Okay, I just unmuted.
Great.
Yes.
Okay, so I don't want to hog up all this time, so I appreciate it. But I do have a question. So my son is 18. He's treated at Children's, and we really love his team. Has nothing to do with that. He was 15. He's had 3 surgeries, one very large one, and then 2 smaller ones. He did test positive for the BRAF mutation. So my concern is he's in college, yay, and I just get this text. Oh, okay, I feel another lump on my throat. Okay, and I'm so sorry because, you know, as a mom, it just puts you into a spin. And we have talked to Dr. Parikh and Dr. Hawkins, you know, prior to this, but like at what point do we really stop looking at surgeries? And, you know, we were thinking about keeping his care at Children's until he was finished with college. again, we really like his team, but now as you know, the more like the alcohol ablation and the radio frequency, I know I could be wrong, but you know, there's not a lot of research for pediatrics. And so at what point does it make more sense for us to think maybe we need to be in an adult team if he keeps having these, you know, things pop up? So I don't know if that's even a valid question.
It's a great question. Situation. So I guess we'll take turns. Jonathan and I didn't work out who's going to go first. We get two opinions, so we'll see. Hopefully, we're on the guidelines together. Hopefully, they'll at least be close. So at 18, I think you have, you know, it's nice because you have options. So if there were non-surgical techniques at Children's, you could stay at Children's, but if they're not, then you always can get a second opinion. And now that he's 18, you know, that would be an opinion you could get almost at any, you know, thyroid center, pediatrics or adult. So there's in pediatrics at our center, we do ethanol ablation for persistent, minimally, you know, not large lymph nodes, but one or two lymph nodes less than a centimeter in size. We use percutaneous ethanol ablation after we've established that they're positive on FNA. So the way that we've set it up is, you know, someone has a biopsy, there's a rapid on-site assessment to confirm that it's PTC, and then during the same session, then our interventional radiologist will inject a small amount of alcohol. So it is highly effective. It's nice because it's not surgery. With ethanol, at least in our experience, sometimes it takes more than one injection. And if the lymph node's bigger than a centimeter, it makes it highly likely it'll take more than one, and depends then if it's really like a centimeter and a half. So sometimes you have to, ethanol isn't the greatest technique. The other thing that we're adding in the next couple months is fiber optic laser thermal ablation. But as you mentioned, there's radio frequency ablation, there's high frequency ultrasound ablation. So I think getting an assessment is, you know, one, figure out if that lump is something that's worrisome. He could just have a lump that is not, you know, a
Yes.
lymph node, is the next step. And then from there, if the ultrasound looks convincing, then talking to your team at Children's or whoever, you know, does the ultrasound, then talking about, you know, being referred, or at least just making an appointment at the thyroid center in Seattle, the adult center. And you could probably even contact them before to see if they even do non-surgical ablative techniques, right, for persistent positive lymph nodes. So I'm sure Jonathan will say the same thing. We get questions about this all the time. I just had someone actually text me a picture of their son's daughter's neck actually looking up with a lump, but it was up here. And it, you know, there's colds going around right now, so there's lots of ways we can give you a lump. But I think that's what we would do. You know, I think what you mentioned are reasonable. You just have to see, one, if it's concerning, and two, you know, what's available.
Yeah, and you know, I think we're in a bit of a different situation at my institution because we're required to transition at age 18 for the most part. But you know, it's not all that different from, in my situation, sometimes a 17-year-old child who's really, you know, close to the age of transition, or could easily have started their care at one of the adult hospitals. I don't think there's a right team or a right time or a wrong time if you have the option. And first of all, it's great that you feel very comfortable with your current team. I know I maintain a very close relationship with my colleagues across the street. And so I'm, you know, sort of picky and choosy about who I transition my patients to, and do know, you know, if there's an individual patient who would benefit most from this particular surgeon's skill set or personality, then I can help do that. And so I don't think it's a wrong time now to start having that conversation about transition with your current team. I think with the immediate issue about evaluating the lump that he feels right now, I think the team that knows him best is going to be the team that will help support you through evaluation of that. And as Andy says, it may or may not be something that requires further intervention. And then should it be a recurrent lymph node related to his thyroid cancer, then it's a matter of exploring who's got expertise in those specific techniques. I know that no one at my hospital has done ethanol ablation for thyroid cancer. And so if I had a patient that I thought was a good candidate, I'd work with one of my colleagues across the street, either have them come over and do the technique with our physicians or arrange for the procedure to be done by someone who has the experience in doing that. We're also looking at RFA at our center and across the street, but that's something these are emerging technologies. And it's something that I want someone to be familiar with the technique, specifically for thyroids, because there are components of RFA or ethanol ablation that are different than when used for other diagnoses or other indications, including how they approach and what they call hydrodissect out the tissues. So rather than where it's being done, I think the decision, is it appropriate? And someone who has experience in the technique will be able to answer that first, that this is, gosh, this looks like it's appropriate for doing RFA or ethanol ablation. And do I have the skill set to be able to offer that?
Thank you. Yeah, he has a ultrasound. It's already been scheduled for Thanksgiving, but it's just, we've never had it seems like, when are we ever going to have a clean ultrasound or not a lump scare or something? Yeah. And so that's where it's like, how heavily do I need to start researching non-surgical options? So when I can help him, I'm not, we're not bombarded and trying to make those decisions,
Yeah. And Andy made a really nice point at the end of his talk at the last hour, in that although we don't want to rely on it with this diagnosis, we do have the time to identify, this is something that affords us the opportunity to evaluate it and work these up appropriately and seek the right treatment for the right patient with the right person at the right time. And there's, with the transition process at Seattle, in as much as it's not a defined time where that we're working off, there's sort of an opportunity for a handover and an opportunity potentially for his current team to work with the future team to gradually transition him over.
Thank you.
Your other question was harder, when to stop worrying. I'm not sure that's answerable. Like all of us, if we went through it or for our patients, it's always going to be a question. So now's the right time to look into other options, because if it doesn't end up being, at least you've taken the time to look into the other options, and waiting to Thanksgiving is absolutely not going to change outcomes. So it sounds like your approach is really already kind of thoughtful and very purposeful, without, I'm sure you're worried, but waiting till Thanksgiving is still good, not to disrupt his school schedule, as long as it's not driving him crazy too.
Yeah, exactly. Thank you.
Yeah.
And we have a question in the Q&A from Stephanie. If positive antibody numbers continue to go down after treatment and eventually hit negative, could the antibodies return again?
That's a great question. It's funny that I was just sort of thinking about that very question myself. I've never seen it happen. I don't think theoretically it could. I don't know, Andy, in your experience, if that's ever happened. I don't know of any literature or any reports in the medical literature describing that, but I wouldn't think it's unfathomable. I just haven't seen it myself.
I can't, the only time I think I've seen it is when the assay changes. So sometimes the assay sensitivity will change.
Yeah.
The older assays might be less than 20, and then it was undetectable, and then all of a sudden it's on a third generation newer assay, and all of a sudden it's detectable.
Yeah, that's a good point, because I just had that happen with a patient, but we knew why it was, and so.
Right, or if you switch labs, or if the lab just switched their assays. But someone who has used a high frequent, ultra sensitive TG antibody assay becoming undetectable and then detectable, off the top of my head, I can't think of anyone, as Jonathan mentioned. In contrast to someone, they just never go away, and it drives us all crazy, but they just never go away. or you start to see it go up. So if it's stable and it starts to go up, then that's consistent with that there may be thyroid cells that are growing, and thyroid cancer cells that are growing would be the assumption until proven otherwise.
So I see a few more questions in the Q&A. One from Sveti's mom that said that your daughter had an ethanol ablation at CHOP and is now 17. She wants to stay with CHOP as long as she can. I think she's well advised. She's got an excellent team there, but I also know that they have great colleagues down the road. So eventually, when she is ready to move on, that I suspect that they'll help transition to an equally capable and skilled team.
I think that's fair, but 17, she's still safe at 17.
Dr. Bauer is going to see how high he can push the limits.
27.
And then Sveti wanted to know, are you researching any new thyroid cancer cells or finding new things about thyroid cancer that you haven't researched before or found interesting while you were doing your research? And that's a great question, Sveti. I mean, I think one of the things that drew me and probably Dr. Bauer into medicine and into medical science has been the fact that we're never done answering these questions, and that any time that we complete some research or discover something, every discovery leads to 5 or 10 new questions, and that's probably the most exciting part of my career is not when we get the answers, but when we start to come up with the questions and the ideas. And one of our colleagues a week ago said, "Gosh, have you ever seen this?" And we were discussing it, and it just brought up all kinds of great new thoughts about how we can gain more insight into disease that we didn't understand before. So I think it's an always evolving process, Sveti, and one that we always try to identify, what are the questions that are most in need of answering to help improve the care that we give our patients. And sometimes there are immediate rewards for patient care, and sometimes we know that we're asking some questions that are very, very basic questions about biology and how cancers behave that we know may not change medicine for decades, but we know that by taking one step forward now, eventually that'll take us there.
Yeah, and I mean, it's a great question. And actually one that both Jonathan and I are working hard and have people helping us to work hard on. So we had 2 recent, in pediatric thyroid cancer, I think the nice thing is there's a lot of discoveries that still need to be made because there's been very little research to try to figure out why kids get thyroid cancer and why it behaves as it behaves. And for most patients, that's actually favorable. So there's less patients that radioactive iodine doesn't work compared to adult patients. So Dr. Wasserman just recently published a really, really nice paper looking at not just the DNA changes, but after the DNA, what's the expression of those genes and how is that different than adults? And so that's one of the earliest, most comprehensive transcriptosome paper. But from that, we're going to start looking at thyroid differentiation scores and other reasons to try to figure out why pediatric patients, papillary thyroid cancer for the most part, behaves favorably. And some of that information we're also doing in our lab at CHOP and working together. But it will also help adults, because if we can figure out how it stays more responsive to radioactive iodine in pediatrics, maybe that same type of genes and expression profiles will apply to adults and help predict which adult patients will respond more or less to radioactive iodine. And then the other really cool thing right now in pediatrics, I mentioned during my talk too, is there's some of these new drugs that can help the cells be more sensitized to radioactive iodine. So we have a study that we're starting now at CHOP, but again, with our consortium, and Dr. Wasserman's part of that, we're working together to try to figure out how does that actually work, because we know it works clinically in a small number of patients, so we need more clinical information, but we can now put that into the lab in cell culture models and mouse models to try to figure out exactly what's happening within those cells, and especially how long is it sustained for? Does it continue to work for indefinitely, or does it break free? And if the cell escapes from that inhibition, then what are the molecules that they're using being overexpressed or underexpressed to escape from the response to those drugs? And are there other targets then that we can then use if the initial inhibitory drugs fail? So it's an awesome time, Sveti. If you want to finish your undergrad and get your grad degree and join our thyroid efforts, that would be awesome.
Is that a
Lots
job
of cool
offer?
stuff. We'll find something.
Yeah, since both of you are here, maybe I'll just pick your brains. I know Dr. Bauer kind of knows my situation with genetics and things like that. I think we probably have a very unique situation with our family, to say the least. About 15 years ago, my husband and both kids were found that they have a PTEN mutation in the promoter region, a VUS variant of uncertain significance. And we just had it looked again a month ago, and it was still considered a VUS. And then about a year ago, they tested positive for DICER1 mutation also. So, and we're currently with Dr. Schultz, Chris Ann Schultz. I know Dr. Bauer referred us to her. You know, she's been wonderful and working with surveillance and things like that. I'm not sure in your practice, you probably don't have any other patients with both mutations, or, I mean, we're doing molecular testing on Alyssa's thyroid tissue right now to try to determine, you know, if they're seeing a DICER1 hit or what they're seeing in that area. But any advice for me, or?
You know, Andy can weigh in as well. I think you're in good hands with Chris Ann in terms of, you know, both understanding the medical management, but also, you know, contributing to understanding of the disease process. I think both DICER and PTEN, in many ways, they're very similar, and I've never run into them happening together. But the way they impact the thyroid gland is different than other gene mutations or gene variants. And I don't really, I've struggled a lot with the biology of what they're really doing. For many years now, for about 30 years, we've sort of understood how some classical genetic changes cause normal cells to go rogue and become cancer cells. And that's formed the framework of our understanding of colon cancers and of other many other cancers. And DICER and PTEN don't necessarily seem to follow that script necessarily. So I think we're still trying to understand from a basic science perspective, how they impact thyroid glands and other tissues, because they're a little bit different. And I think we're still, especially with DICER1, it's very recent, fairly recently in the scheme of medical science. So I think there's a lot to be learned, and you may or may not know that the way DICER impacts the function of the cell is through a mechanism that's also a fairly recently understood concept, something called microRNAs, which we identify them and we can find changes in them, but it's very hard to, as someone who's studied genetics now for 30 years, I still struggle to wrap my head around how different microRNAs are affecting what cells do and why they change and become less, they follow their instructions less well. So I think it's early days for our understanding.
And Pam, from Chris Ann, because I haven't had an update in a little while, on the clinical side, are they recommending following the DICER1 surveillance, so pelvic ultrasounds?
Yes. So both of them, we have quite a list of surveillance.
Right.
For
Because now
both,
you have both surveillance, right? So
both surveillance, yeah. So I said, maybe they'll hit a sweet spot in their late 20s, but usually DICER1 is correlated with cancers at a younger age, and the PTEN, it's usually kind of an older, 40s and 50s. But yeah, they're doing the pelvic ultrasounds to look at the ovaries and kidneys every 6 months. Haven't started the breast MRIs or imaging yet. My oldest is 26, but you know, that will be coming. So yeah, the P10 comes kind of later in life.
Right. And the dicers, you've already heard, I'm sure, from Chris Ann, and we've talked about too, is it's another strange syndrome in the sense that you can live your whole life and have a dicer that's detectable in your blood, that you actually have a germline mutation and never have any of the tumors that are associated with it.
Right.
So the surveillance for the ovarian tumors, I think, continues into the late 20s, and then that kind of backs off. But then more importantly for the, you know, if they have kids, say it again.
Till 40, she said.
To 40.
Yeah.
And you know, as it goes, well, the surveillance patterns sometimes change. So, you know, going to gene reviews, talking to Dr. Schultz, keeping in touch with us. The goal is, you know, a balance between not driving people crazy and trying to catch things early. And sometimes that sweet spot, whoever used the word sweet spot, is hard to figure out that drive people crazy. But for the, you know, if they get married and have kids, then that's when dicer becomes really important, is for the infant, for the lung lesions that can happen.
Yeah, I just think it would be interesting to know what caused the thyroid cancer, whether it would be the P10, the dicer one, or a combination. I don't know.
No, that's exactly what Jonathan was alluding to. That'd be interesting to look at.
It could be neither, Pam. Just to
oh my
complicate
gosh,
things,
there could be another one out there.
Well, not that there's another one, but you know, for example, with P10, overall, 35% of people with P10 develop thyroid cancer. That means 65% of people with P10 don't develop thyroid cancer.
Right.
And dicer is probably even a you know, bigger percentages that don't. So certainly there's a smoking gun in terms of potential, but these, you know, I think there's still a lot to be understood, and how the two interact is itself also very very challenging.
Yeah.
And the talk earlier from Dr. Nikki Foroff, Pam, I know you were on that as well. I was listening as well. You know, the strange 6 patients now that have been documented with the poorly differentiated thyroid cancer for dicer 1. Again, as everything in life is, nothing's 100%, but I think that's exceptionally uncommon and not a risk because they don't have their thyroid anymore.
Right. Yeah.
For the majority of patients, P10 and dicer, they're usually very indolent, very non-invasive forms of thyroid cancer. They definitely get lumpy, bumpy thyroids, lots of nodules. But the type of cancers they develop are usually ones that most of the time are actually confined to the thyroid and don't spread. So it's the other stuff that we briefly touched about, the surveillance part for the other types of tumors that really becomes the critical part for P10 hematoma tumor syndrome and dicer 1 syndrome.
And I think, again, when they have children, to be able to, you know, if it is dicer 1, which is associated with a lot of childhood types of tumors, cancers, lung cancer, to be screened for that, or, I mean, just, I think that's the power of knowing.
Right. And usually during the fetal ultrasound, you'll see the PPBs, if they're going to have them, that they're cystic lesions. And all babies that are born to a family that have dicer 1, then they get early chest screening as well, whether it's CT or MR, because if it's going to develop, it develops before age 5. And if you catch it early, it's treatable. If you catch it late, it's sometimes not treatable. So it's one of those ones that surveillance really has been a huge impact for patients and families that have dicer that runs in the family.
Yeah. Okay. Thank you very much. Oh, go ahead. Sorry.
No, I was just going to say, I see there are a couple more questions in the Q&A.
Yes.
And I'll address those, and we can circle back some more. So Kelly asks, in a session yesterday, the presenter mentioned extrathyroidal extension. And how can this be evaluated and discussed in the pathology report? Could you explain extrathyroidal extension and how looking at that informs treatment? So I'm going to try to share I just Googled a nice picture, so I'm going to try to share that if I can. So what extrathyroidal, is it showing up, Andy, on the screen?
Yep, it is.
So
can you zoom in a little bit? It's not,
I can't. Oh, yeah,
Other
sorry.
people can. It's fine.
These are the limitations of my technology knowledge.
Of Google.
Yeah, but extrathyroidal, so most often a thyroid tumor is confined inside the thyroid gland itself. It sort of sits in the middle of the thyroid gland. And that's shown here. You can sort of see that the dark pink here is buried inside the thyroid gland. But in some situations, it extends outside of the thyroid gland and can spread either into the muscles that are over top the thyroid gland or into some of the other structures in the neck, and that's called extrathyroidal extension. And in past, that was considered both a diagnosis made under the microscope, what we call minimal or microscopic extrathyroidal extension, in addition to what the surgeon saw at the time of surgery or even before the surgery with ultrasound or CT scan. For those that had either form of extrathyroidal extension, the likelihood that it would be more challenging to get all of the disease and to treat all the disease was higher, and that the surgery would be more extensive. I think in more recent years, and this is largely based on information from adults, Andy can speak to some information from children as well. When the surgeon doesn't see extrathyroidal extension with his eyes or her eyes during the surgery, and it's only visible with the microscope, it's what's called microscopic or minimal extrathyroidal extension. And that in and of itself may not change the ultimate risk for those individuals. But really the extrathyroidal extension means any time that thyroid cancer cells spread outside of the gland itself. A similar phenomenon talks about the lymph nodes, which are shown here in yellow. And sometimes if the lymph nodes contain cancer cells, it stays within the lymph nodes. But in other cases, it can spread outside of the lymph nodes, and that's called extranodal extension. And that suggests that there may have been cancer cells that have escaped into the tissues around the lymph nodes. In both cases, when it's microscopic and patients have radioactive iodine, it's often a sufficient treatment after the fact to address the remaining cells behind. But that's really sort of in a nutshell what extrathyroidal and extranodal extension are. And I think the next question is going to get to that as well, but maybe I'll pause there and let Dr. Bauer add his 2 cents.
And then Kelly can let us know if we answered it fully.
No, actually, it's a good point. Please, follow up with questions. If we don't answer your question, or if we lead to other questions, please feel free to add that into the Q&A or to raise your hand, because we're happy to address that.
Everything that was just reviewed is more detail. It was very nicely done, and the picture actually is nicely represented too, without having to show a photo micrograph of the thyroid under what it looks like under the microscope. So clinically, what the significance is, it just helps define what the behavior is. So the cells are trying to move, and there is an association between microscopic extrathyroidal extension and having lymph nodes that are positive, which kind of makes sense also. So if the tumor cells are in a encapsulated nodule, oftentimes they're not going to spread even within the thyroid. But if it's not encapsulated, or if it breaks through the capsule and it even starts to grow outside of the thyroid, then that tells you that those tumor cells have gained the ability to spread. And if it's spreading outside of the thyroid, even microscopically, there's a chance that the lymph nodes may be involved as well. It doesn't really change the outcome. It just changes the ability to say, is radioactive iodine going to be beneficial or not, depending on how extensive the surgery was, if lymph nodes were removed or not, and how many were positive. And the only other thing about the extrathyroidal extension is we usually only refer to it in the front part of the thyroid. So the part that's just under the surface of the skin that's facing forward. The back is a little more difficult, because the back of the thyroid is kind of connected to the tissue back there, and it's always hard to at least our pathologists tell us it's hard to say, is it in the thyroid or not in the thyroid, because that line, that border is not as distinct as the anterior border, the border that's facing forward. So it's gone back and forth. In adults, they get rid of it as part of a staging system because it didn't change the outcome, unless the surgeon can physically see it with their eyes during surgery, that it's not just on the surface, but it's into muscle and soft tissue or into the trachea or something else. Did we answer the question?
I'm going to stop sharing. Just take the picture off. I don't know if Kelly, if we didn't answer the question, feel free to
Right,
put
another question.
She says, yes, thank you. So Stephanie asks, my daughter has been diagnosed with diffuse sclerosing variant. She had extrathyroidal extension and positive lymph nodes and positive antibodies. We're in our first year since diagnosis, but wondering if or how the variant affects your considerations in the first few years of follow-up. So the diffuse sclerosing variant, for those of you that aren't familiar with it, is it's described in adults, but very, very rarely. It's probably less than 3 or 4% of adult thyroid cancers, but much more commonly seen in children, and particularly in younger children. So the diffuse sclerosing is just a way that the pathologists use to describe what the cells look like under the microscope. But we know that when the cells do look like that under the microscope, and sometimes we can even tell from the ultrasounds, that they behave differently than some other tumors. And it's very, very common, almost universal, that there is spread of the diffuse sclerosing variant cells into lymph nodes. And I think almost 100% of the time, the antibodies are positive too. So what you're describing is very consistent with what one might expect from that particular form of thyroid cancer. It does obviously affect the initial treatment and the surgery, because if I see a child who has an ultrasound that makes me suspect the diffuse sclerosing variant, I'm going to insist that both my surgeon and my radiologist take an extra hard look to make sure that we've identified and looked at all of the lymph nodes in the neck before surgery. So we can make sure that our first shot at surgery is going to be as good a chance at surgical cure or surgical treatment as possible. I don't want to go in and have anything missed. In terms of follow-up, I don't know that there's a significant difference. It's really, the follow-up is going to depend on how things look after the surgery. And so the first visit typically after the surgery, at least to the endocrinologist, not the surgeon, who's more focused on looking at the incision and making sure there aren't immediate surgical issues, is what we call staging. And that's an opportunity to evaluate whether or not we are concerned that there's anything remaining. For those of you that were at Dr. Angelos's talk, he stressed that any thyroid surgery, even if they call it a total thyroidectomy, is expected to leave some thyroid tissue behind. And we want to know at that staging visit whether or not there is any detectable thyroid tissue left. With the diffuse sclerosing variant, because it tends to be more extensive, the likelihood is going to be higher, but not certainty, that there is thyroid tissue left. And in those cases, if there's thyroid tissue left, we'll be inclined to recommend radioactive iodine treatment as an additional means to try to eradicate remaining disease. And then after that, it's going to be a matter of the dynamic risk assessment at various points in the follow-up. Is there still evidence of disease, or do we think that we've achieved our stated goals of achieving undetectable disease for now? Anything to add?
No, I think the only other thing to add is, you already mentioned it, but just to kind of say it again and add a little bit to it, is the majority of patients will have antithyroglobulin antibodies that are elevated. And we've had several patients that, if things are progressing, that those antibodies need to be followed, because if they're increasing, that means that It's similar to the TG. It's instead of TG, we're using the TG antibody as the marker. And if they go up, then they really need to, make sure that the ultrasound is repeated, and looking in the neck would be the most commonplace an explanation. But then depending on how high the antibody levels were, and if something's found in the neck or not, then you think about other imaging, the chest being the next most common. So it's just one of the forms that's more likely to spread, oftentimes limited to the neck, but then the outside of the neck, the second most common place would be the lungs. So just the one that we really keep an eye on patients, and patients do well, but it's definitely a little bit more intense surveillance. And of the patients that need more than one treatment, I think it's a higher likelihood, but not everybody, a higher likelihood for our patients with diffuse sclerosing variant.
Andy, do you want to take Sveti's question?
Sure. So I saw a session yesterday that talked about salivary gland problems. Sometimes I feel like I have something in my throat when I'm swallowing. How would I know if I had salivary gland problems from radioactive iodine? Which is a great question. So the salivary gland problems after radioactive iodine kind of happen in 3 different time frames. There's some that can happen right after radioactive iodine, and you'll know about those because it's usually within a couple of days. You get redness, swelling, pain, most commonly in the parotid glands, sometimes in the submandibular. So we have a couple different salivary glands that are located along our jaw or just below our jaw. For those patients, I think they're at higher risk of having the further longer term complications, although not all of them will. But even outside of that, if you didn't have that, sometimes down the road, you can still get some block in the path where the saliva is leaving the gland into your mouth. There's a duct, a little path that the saliva goes through, and the radioactive iodine can irritate that path, and it's very small. And if it irritates it, then it can stick to each other, and the walls stick to each other, and you can have decreased flow even 6 months, 12 months down the road. What you'll see then is still it can swell and cause discomfort, or when you may not notice it unless you're eating sour or spicy things that make your salivary glands more active. So that can be the trigger. And what patients typically report is if they're having the obstruction, the path is closed down, whether it's fully or partially, they'll have dry mouth more frequently. They'll have an increased risk of cavities because our saliva is important to wash the stuff, food particles and sugar and things like that off of our teeth. So it can be pain, swelling, discomfort. It can be dry mouth, persistent dry mouth, and increased cavities. Throat pain is a little less common as a single feature without those other things going on. Obviously, if you have a dry mouth, you may have more likelihood to have, discomfort and difficulty swallowing, but a little less common as a single indicator for radioactive iodine having damaged the salivary glands. So if you have continued throat pain or clearing, you think about other things like reflux is a common thing that people can have. So it depends where in your throat and when it, how long it's bothering you for. Is it staying the same? Is it getting worse? But all those things we can think about and evaluate. And if it doesn't go away and it seems to be more swallowing, then sometimes our gastroenterologist will put a little endoscope down and they can take a look and make sure that the walls of the esophagus don't look irritated, that there's something going on, polyps or evidence of reflux. Or if it's more, upper airway or airway itself, then the ENT doctors would take a look. But as a single thing, I think it's less common to be radioactive iodine, but it's still something that we should know about if it stays and something that we should look into.
Yeah, and I would just add to that, we don't always know. What you're describing is sometimes called by doctors a globus sensation or feeling of things getting stuck. We don't always know what the cause is, whether it's because of not enough saliva or because of other irritations like reflux that Dr. Bauer mentioned. Certainly the ear, nose, and throat doctors that I work with, and one of them is an expert in saliva and salivary glands. The first step that he recommends, even when it's known dysfunction of the salivary glands is try increasing fluid and increasing water intake. And that often in and of itself, by just drinking a lot more water during the day, is enough to get rid of that sensation. If it's dry mouth, and if dry mouth, if it's of things getting stuck. And it's probably the least invasive and most effective, although it's low tech steps to really help with that. But if it's something that's persistent, that's getting worse, that's interfering with your quality of life or your ability to eat, then it's definitely something that's worth looking into further. Either, the border between the ear, nose, and throat doctors and the gastroenterology doctors is sort of the collarbone. So it sort of depends where you're feeling it. And then they may, even before using that camera, they may have you swallow as kind of dye to look at your swallowing. There are different techniques that can be used, but really I would suggest first trying to increase your water intake, maybe buy a hydro flask, or I can't remember what the other brands are. I'm not pushing a particular brand, and try to finish a full one every day and see if that helps.
Any other questions? We have about 10 or 15 minutes left. If anybody else wants to chime in for a question. No more questions?
We've answered everything.
Wow. They're such experts. They know everything. So
Far from it. That's not what my son would say.
okay. All right. Well, I guess we'll quit early. If there's no other questions, unless Dr. Bauer, Dr. Wasserman, if you have any comments to add.
I think I just want to say to commend everyone that's here. I think it's great, particularly for those adolescents and young adults that are on the line, but also the parents that you're learning about your medical condition, advocating for yourselves, trying to really solicit more information, and that's really rewarding for us. And so I thank you for that. And I think it's really helpful for us to know what questions you have and what concerns you have, so that we can do our job better at sharing in your care. Mm-hmm. And it's really the great honor of our lives to be able to participate and to be part of this odyssey. And so we thank you.
Okay.
I echo that as well. And the only other things I would add is, every year we kind of work together, Jonathan and Gary and I and Pam, and try to come up with ideas. But if there's certain topics that we haven't addressed, when you fill out your surveys or your evaluations, mm-hmm. please let us know, because we could, we had a radioactive iodine discussion actually on the schedule, and then the person who was going to give the talk couldn't make it. But knowing what you guys are interested in hearing is super important for us. And we obviously have the ability to change things. We talk about thyroid hormone replacement. There's lots of topics all of us are interested in. And so just let us know if there's things that we could and should be covering that we haven't.
So I just noticed in the chat, there was another question that I don't think we addressed.
Oh, yep,
from Linda. It says, my 20-year-old daughter had a total thyroidectomy. It was negative. Can she still get MTC even though she has the RET gene? So presumably this is an inherited RET gene. That's a tough one. So the easy answer would be the likelihood is exceedingly small. And I think you can sleep at night. We do know, and just came up, that a total thyroidectomy it almost inevitably leaves one or two cells behind, thyroid cells, in the hands of the best, most skilled surgeons in the world. But the likelihood of that after a total thyroidectomy becoming medullary thyroid cancer is exceedingly small. In fact, we rely on that approach even in young children to prevent cancer from developing. And so your daughter, who underwent the recommended surgical approach, should feel comfortable. I think it's still wise to continue to follow with a physician and to have calcitonin levels checked. every so often. I don't know quite how often that would be, given the negative histology. There are some changes that we see in the thyroid glands when they look under a microscope that show beginning of changes towards medullary thyroid carcinoma, called C-cell hyperplasia. And if they had seen that, it's not a cancer, but that would make me want to check blood tests a little bit more frequently than if that wasn't there at all. She had hyperplasia.
Chin hyperplasia. Yeah.
Yeah, I'm just looking at the chat.
Yeah.
I'm getting the running commentary from Linda.
Yeah.
So and the other thing with the as you've alluded to in the chat box, is that there are other medical conditions that we screen for. And so as part of annual visits for pheochromocytoma and for hyperparathyroidism, screening will require evaluations and blood tests. And so if she were following in my clinic, then we would include calcitonin probably in addition to checking a calcium level and the pheo hormones, epinephrines.
Okay.
Yep.
Any other
see-
questions? Oh, go ahead, Dr. Bauer. I'm sorry.
No, I didn't. I was just going to say I didn't see anything else. I think Jonathan answered all those. The other thing I was going to say before the final question, or if I keep talking, maybe there'll be one more. We'll see. Is that we had worked to update Jonathan and I the pediatric handbook for ThyCa, and I think according to Gary, it should be out in the next couple of weeks. So again, it's one of those things that we take some time to try to provide some education and information, but if there's areas even in the handbook that we're not covering or you have questions on, let us know, because again, it's a resource that we want to be as useful for you guys as possible. But that should be available on the website, I think, in the next couple of weeks.
Okay, sounds good. Well, thank you very much. Again, we appreciate your time. And thank, of course, for everything you do for ThyCa, for us as patients. Again, we greatly appreciate it. So thank you, everybody. Have a good night. Hope to see you at some more conferences tomorrow. Thanks.
Bye, everyone.
Thanks for the invitation. Thank you, Dr. Bauer, for the
Thanks, Jonathan. Yeah, it was good.
invitation.
Fun together.